Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, listeners. I'm Lindsay Smith Rogers, producer, Public Health on Call. Our last episode of 2022 will be December 16th. We'll return with a new season of the podcast on Wednesday, January 4th. In Season 7, we'll be launching Climate Mondays, a series of episodes dedicated to hope and change. Guest host Shelley Hearn, director of the Johns Hopkins Lerner Center for Public Health Advocacy, will talk with leaders working at the intersection of climate change and public health, doing innovative work with the through line that we can do something about climate change. These conversations are fun and engaging, and we hope they'll bring fresh energy to an often daunting topic. We'll also continue to talk about COVID and other infectious diseases, aging, mental health, solutions for gun violence, and more. And of course, we'll continue to cover the need for investments in public health infrastructure and surveillance for future pandemic threats. A few thank yous as we wind down this season of the podcast. First, to our interns, Kriti Baum, Caroline Wang, and Hannah Bennett, who bring fresh ideas and much-needed support for the team. We'd also like to thank you, our listeners, for sharing your ideas and questions and for downloading this podcast nearly 10 million times. We appreciate all the great ideas and questions that come from you, so keep writing us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu. Thank you for being part of this podcast. Last week, hundreds of public health leaders and scholars gathered in Philadelphia for the annual Bloomberg American Health Summit to discuss critical topics ranging from gun violence and environmental justice to food policy and preventing overdose. This special episode of Public Health on Call features 3 panels from the main plenary session. In part 1, experts discuss extreme risk protection orders as an evidence-based solution for preventing gun violence. Let's listen.
Please welcome Senior Advisor for Implementation at Everytown for Gun Safety, Ruhi Bengali, Co-Director at Johns Hopkins Center for Gun Violence Solutions, Josh Horowitz, and your moderator, Managing Director of The Trace, James Burnett.
Thank you, Janelle. Thank you, Josh and Ruhi, for the insights you're about to share. Look, any conversation about gun violence, it has to acknowledge the lives lost. But it's equally important to acknowledge the progress that is being made, because that's how we understand this issue, not as intractable, right, but as something we can solve together. Josh and Ruhi are going to share what's giving them hope, what they see as some of the unfinished business for the public health model for violence prevention. We're also going to take your questions at the end, so please get those ready. Let's dive in. Josh, one of the bright spots in violence prevention has been something called extreme risk protection orders. Bring us all up to speed on what those are, how they work, and importantly, what do we know about their effectiveness?
Thanks. Extreme risk protection orders are state laws that create a civil legal process that law enforcement and in some states, family members and increasingly medical providers can ask a court to remove a firearm from someone who's at risk to self or others. They're modeled on domestic violence protection orders, so similar to those, it's a civil process, except these are focused on firearms, the removal of the most lethal means. So far, the evidence has shown that when it comes to harm to self, we're starting to get a body of evidence where the arrows are pointing that this is actually an effective strategy. Now, let me say, these are all these laws are new, so we're really starting to collect the evidence. And then when harm to others, interpersonal violence, the research is really early. But there's definitely some qualitative research that shows that some of these cases have been used to remove firearms from people intent on mass shootings like school shootings. So I'm very hopeful for these. They're in the infancy, and we need to go beyond the 19 states and the District of Columbia that have them and implement them in many states, more states across the country.
Let's talk a little bit more about the implementation. Ruhi, in some jurisdictions, we're seeing that it's law enforcement and city attorneys who are the most avid users of ERPOs. What needs to happen to ensure that these policies are used as a public health tool and embraced by clinicians and community members?
As Josh mentioned, extreme risk protection orders, or ERPOs, are an effective gun violence prevention tool that have gotten a lot of positive attention the past few years. And we need to look further to see where they're being implemented and how. And the data that we've collected shows that there's wide variation across states as well as within states. So Maryland, Florida have the highest per capita rates of ERPO usage, whereas Hawaii, Nevada, New Mexico have really low rates. And what we're finding is that having champions on the ground and having a robust infrastructure for ERPO implementation really matters. In jurisdictions such as King County, Washington, San Diego, California, they had committed stakeholders on the ground who invested in processes and protocols and ensured effective implementation of this tool, which is now, we're seeing that in the numbers. And I say that because at the heart of it, however effective the tool may be, it's not going to implement itself. We need to be investing resources, and so if we want to increase usage across the board, but particularly amongst clinicians as well as the community members, first and foremost, we need to raise awareness. Most practitioners and people just are not aware of the very existence of the tool. Secondly, we need to invest in training resources and modules so that these stakeholders understand when is it appropriate to use an ERPO, what are the steps that they would need to take within a particular state in order to get one, and so on and so forth. And then lastly, because there are so many stakeholders involved at various stages of the ERPO process, there needs to be better communication and collaboration across all of those levels.
So we have ERPOs, we have the Bipartisan Safer Communities Act, we have too many new funding streams, or at least available funding pools for public health interventions, street outreach, the whole list, more than we can get into here. Think ahead for us 5-10 years. What's it going to take? The one thing you think is necessary to make sure that we don't squander this moment, the momentum that the field has?
I think, first of all, you have to take these resources and lean into them. We need champions in every state who are going to say, I will get those grants, I will learn about the Burn JAG program, and I will be the champion for this state. So it's understanding the federal streams of money, having, as Ruhi said, taking a champion who can lean into these things, and then all of us to say, we want to implement this. You mentioned hope at the beginning. I have lots of hope, but hope's not a strategy. Y'all need a strategy. We all need a strategy for implementation, and we're working hard on that.
Ruhi?
As Josh said, implementation is the name of the game. We already went over some of the steps of that. I think in addition to that, those who are most impacted by gun violence need to be part of the solutions. There are racial disparities across the impacts of gun violence, and those communities need to be in the room when we're making decisions on what the solutions need to be for those communities. I think that includes using this funding, these resources, to expand our focus, not just on the implementation of the policies, which is extremely critical, but also to focus on underlying factors of gun violence, such as focusing on investments in housing, employment, mental health resources, healthcare access, the list goes on. It is truly a public health approach to gun violence.
So let's now take some questions from the audience. I think we have time for one, maybe two, maybe three if we talk fast. Who's got a question for Josh or Ruhi?
Are you including emergency departments in the education about this, and maybe integrating this into order sets, for example, in emergency medical and in electronic medical systems?
So Shannon Frateroli, who couldn't be here today, but is leading that effort and trying to create healthcare navigators, so that we're piloting some efforts within Baltimore to look at exactly those issues, how to make this easy for clinicians to work, to do this. Yeah.
Hi, thank you for this important conversation. My question is about do we know about how the ERPOs are actually being used?
We know a little bit. We need a lot more data, but I think what we're finding is that there is research and data to show that, in some states, a vast majority of them are being used in cases where someone is threatening self-harm, is at a risk of harming themselves. But there are increasing number of cases across all of the 19 states that are showing that these are cases where folks are threatening a specific individual or are even threatening sort of mass shootings or school shootings, and those early signs are being picked up and intervened on, and an ORPO is being issued.
We have time for one more.
Good morning. Thank you for a very informative session. I was wondering if you could share your thoughts on what are the most critical issues ahead for ORPO in the US?
I think you need to have more education. We need to ensure there's access for every community, and we need to make sure that we fully evaluate these laws and the data is available.
Thank you, Josh. Thank you, Ruhi.
Thank you.
Thank you.
In part 2, Innovations in Harm Reduction, experts discussed New York City's first supervised injection site, which opened last year. Let's listen.
Please welcome Commissioner of New York State, Office of Addiction Services and Support, Dr. Chinazo Cunningham, Professor of Epidemiology at Brown University School of Public Health, Dr. Brandon Marshall, Senior Director of Programs at On Point New York City, Kaylin C., and your moderator, staff reporter at the Philadelphia Inquirer, Aubrey Whelan.
Thank you so much for that introduction, Jason. I'm really excited to be here. Let's get to it. New York City opened the first supervised injection site just about a year ago. Kaylin, I'm hoping you can tell us a bit about how it works and what sort of challenges and non-challenges you faced in opening it. What was easy, what was hard?
Yes, so I'll rapid fire this because we don't have a lot of time, but November 30th, 2021, the first 2 safe consumption sites in the United States were open, y'all. Let's have it. Yes, they exist. They are safe spaces where people who use drugs can bring illicit materials and use them safely under the supervision of a trained staff. The sites have been used over 50,000 times. They've intervened in 633 overdoses in their first year, calling the ambulance only 10 times. And we have, thank you, yeah, let's clap for that. Quickly, yes, we have no time. And we have 2,200 registered participants at the sites.
Awesome. And what is the funding model for the site? How do you guys work?
Yeah, that's the tricky bit, thank you. So because we don't have federal permission or state permission officially to operate the sites, funding is the big question. So no public dollars can be used to operate the sites. And for any jurisdiction that's thinking of opening their sites, and I know that Philadelphia is, and we're with you all the way in that effort, really securing sustainable funding for this evidence-based public health initiative is going to be key to scaling up this life-saving intervention across the country. So we're really optimistic that the Opioid Settlement Fund money can be used, and we really are calling on jurisdictions to advocate hard for those public dollars to go to operating these sites. For now, it's foundation and discretionary money and donations, so it's a tough position to be in.
Dr. Marshall, you are in Rhode Island, which has also approved sites but hasn't opened them yet, and it went the legislative route. Can you talk about that? And I'd love to hear from you as well, Dr. Cunningham, about kind of how in New York you guys are working at a state level, because I know that the OPSs are operating at a city level in New York City.
Sure. So we were the first state in Rhode Island to authorize overdose prevention centers through legislation, which passed, I might add, with broad bipartisan support.
Yes.
And we also recently are now, as a state, financially supporting organizations that wish to open an overdose prevention center using our opioid settlement dollars, which is allowable under that agreement. So I think what this shows to me, right, is that harm reduction is achievable, and the broad public and political support for harm reduction can happen. And I think Rhode Island shows that. That's really it. Until we think about harm reduction as a key component in a continuum of services for people who use drugs, we're not going to see the end of this crisis. That's simply it. And so we're leading the way, and I do hope that many other states and jurisdictions follow us.
I would absolutely agree about really thinking about harm reduction and embracing it in terms of all of the strategies that we use across the state. And this is something we're doing in New York. So I've been the commissioner for a year, and really my leading priorities are harm reduction, a data-driven approach, and using an equity lens in everything we do. And in terms of the kinds of harm reduction policies and activities that we're supporting, including really expanding harm reduction supply, so naloxone, fentanyl test strips, and supporting syringe services programs, bringing services out to where people are, so really going out into the community, bringing methadone out into the community through mobile units, doing outreach on the streets, on the corners, under the bridges, linking people to care. And so really thinking about harm reduction as a full continuum to reach as many people as possible and those who are at the highest risk.
Yeah, I'm curious if any of you can talk a bit about community outreach, both to, and I hate to draw the distinction between, the community of people who don't use drugs and the community of people who do this. They're all one community, as we all know. How do you do outreach to people who requires harm reduction services, and also people who are living near, the places where these harm reduction services are distributed, and kind of how do you get people on board or, get them acclimated to the idea that, say, there's going to be an overdose prevention site next door?
I think it's important to remember that we open and operate programs for two different stakeholder groups. One, the people who are going to use the programs, but we also open them to address the needs of the people who live in the neighborhoods where these programs are going to be sited. So for us, it was really about acknowledging that there were no American examples to point to, and that we needed to be fully transparent and patient with the communities where our sites were operating, and allow that conversation and allow those deeply held feelings that people have about drugs, drug use, and people who use drugs to come up and not shy away from that conversation. So from our perspective, we opened our doors. We've been open for just over a year, and we've hosted over 400 tours, and we felt that we had a responsibility to do that. So our public engagement strategy was a little bit more after the fact. Sometimes it's easier to ask for forgiveness than permission, especially when you're going to be opening the first 2 safe consumption sites in the United States. But that has really been a winning strategy. When people come and see the sites and how they operate, they understand that we're trying to meet the needs of 2 stakeholder groups, that it is evidence-based, and it is solid public health strategy, and that's won the day for us.
I would also just add to that in terms of who should be doing outreach, what that should look like. It should be everywhere, right? So it should be community-based organizations doing outreach in their community. It should be prevention, treatment, and recovery providers as well. I mean, we have to do things differently. We are at the worst overdose crisis ever in our country's history. And so we have to get outside of the walls of the traditional way in which we've been providing care, and we have to go into the communities. And so supporting all of the service providers is really critical.
I know that obviously, yesterday there was a deadline in the case here in Pennsylvania or in Philadelphia to open a supervised injection site that the federal government has asked for another extension on. I'm curious as to, what either any of you think on, sort of efforts around the country outside of your own jurisdictions to open these sites and how it compares to what you did.
Yeah, these delays are harmful, right? Every overdose death is preventable. And these sites can save lives. They start saving lives the days with which, after which they open. And so these delays are harmful. I think we need to move towards implementation in jurisdictions as rapidly as feasible, and a stronger indication from the federal government that this is an evidence-based intervention that can and should be rolled out in communities that are highly impacted by the overdose crisis would go a long way, I think, to seeing these interventions, open and foster and thrive in communities across the U.S.
Where is Rhode Island in the process right now?
So we are financially supporting these sites as a state through our settlement dollars. That RFP went out and organizations have applied, and we're expecting that funding to be released early in 2023. The legislative and regulatory process we took is slow, and I won't be happy until a site is physically stood up and open. But what we've seen is broad support politically, publicly, through that process. So I'm hopeful that we're building a strong foundation from which to continue to grow and see support for harm reduction more broadly, not just overdose prevention centers.
Can I add one tiny thing to that? One thing that I think is evident is post-opening the sites and because of what's happening in Rhode Island with the legislation is the harm reduction community nationally is working together in a very different way around the launching of the sites. And each jurisdiction will find its own path, whether it's declaring a public health emergency or going the sort of very rapid surprise, non-regulated route that New York went or the legislative route that Rhode Island went. But the harm reduction community and government stakeholders across the country are interested in opening these initiatives and really proactively taking steps.
Dr. Cunningham, in states that are, like Pennsylvania, where we have, kind of more radical interventions trying to get implemented in some of the larger cities, but, there's not statewide syringe access, for example. What can places, with very different pictures of the opioid crisis, what can states do to kind of address the different access issues across a very broad spectrum of people?
Yeah, so certainly in New York, we have a very large state, and we have all the way from New York City to the North Country, which is the area that borders Canada, and they're obviously very, very different communities. And so I think what's really important is to understand what the challenges are in each of the communities, and then think about the potential solutions, which are going to be different. And then I think the other thing is just really learning from each other. I hear sometimes, what happens in New York City can't happen in these other places, and that may be true, but I think we can sort of tweak, we can learn, and we can tweak our approaches accordingly. So I think that is the job of government, to really think about the specific differences and challenges and then meet those challenges.
Great. Thank you, guys. This is just about time. It's been a wonderful discussion, and you were all very quick, so I appreciate that. Thank you so much.
In part 3, experts discuss increases in suicide among youths of color. Let's listen.
Please welcome Bloomberg Assistant Professor of American Health, Department of Health, Behavior, and Society at Johns Hopkins Bloomberg School of Public Health, Dr. Kiara Alvarez, Professor in Johns Hopkins School of Public Health, Medicine and Education, Dr. Holly Wilcox, and your moderator, Bloomberg Fellow and Public Health Reporter at Kaiser Health News, Aneri Patani.
Thank you, Holly and Kiara, for joining us today to talk about this important topic. Over the past few decades, we've seen an increase in thoughts of suicide, suicide attempts, and unfortunately suicide deaths among many youth of color, including Latinx youth. Kiara, could you talk to us a little bit about what are the concerning trends that we're seeing and what are some of the factors that might be behind them?
Absolutely. So one of the challenges that we see is that we have this idea that suicide risk peaks in middle age. We've heard that statistic. But when we actually look at subgroup differences for people of color, the risk actually peaks in adolescence and in young adulthood. And so it's a different pattern that really speaks to the need for early intervention. And at the same time, we see these massive disparities in the kinds of mental health care that youth of color are getting. And so including for Latinx youth, we see the lack of access to preventative care and to mental health care when there is suicidal ideation and behavior. But we do see that there's a greater likelihood of them receiving services through emergency departments or of being funneled into punitive systems, school behavior concerns, as well as the juvenile justice system. And so without addressing those inequities and understanding what the underlying factors are, it limits our ability to engage in effective prevention. And for Latinx youth specifically, there are barriers for particular groups, including language access, low rates of insurance in many states, and the lack of culturally competent care available to families.
Yeah, I really appreciate you comparing when we have different risks, different populations, there's different risk factors, and therefore our policies have to address different issues as well. So Holly, I'm hoping you can talk to us a little bit about, there are policies that are being tried at state and national levels to address this issue. What are some recently passed ones that are trying to address youth mental health and suicide prevention, and how do you think they might affect Latinx youth especially?
Sure, I'm going to focus on some policies that are in the public health realm. And one of the barriers that we face in the field of suicide prevention is getting evidence-based practices out to those who need them, when or before they need them. And so there's a great policy that, or law that was passed in California. It's Senate Bill 224. In California, about 40% of the state is Hispanic. And so it will benefit lots of youth. And the idea is that mental health education will be embedded within health education for students in grades 1 through 12. So students will get developmentally timed mental health education in elementary school, then in middle school, and then again in high school. And they'll receive it by trained, highly qualified implementers or instructors who will deliver the training. And the whole idea, another idea behind this training is it will be given directly to students, but also that that it will be appropriate for a diverse student population, diverse by gender, diverse by race and ethnicity, by gender and sexual minority status, students with disabilities, and English language learners, which are, those students are often excluded from our traditional suicide prevention interventions because of difficulties schools have with having a Spanish-speaking implementer and pulling students out and so forth. And so I'm excited about this momentum that we have a silver lining in the pandemic. Another is the Stand Up Act, which is a national law. President Biden signed it in March of this year, and it is a suicide-specific policy that will enhance the ability to bring awareness and prevention to students in schools, grades 6 through 12. It focuses on, it's actually implemented through the Project Aware mechanism through SAMHSA, and so states and local education authorities and tribes will have additional funding to support suicide prevention evidence, and students will get it directly. In the past, there was a lot of effort on focusing on training adults that work in school buildings, and unfortunately, that hasn't shown to have the research impact that we need to achieve to make a difference. And so the direct provision of the intervention to students is the idea behind this law, which is evidence-based, which is fantastic. And also the Bipartisan Safer Communities Act has some additional funding built in for continued dissemination and enhanced dissemination of this Stand Up Act.
Yeah, I love the emphasis on training students. We heard Attorney General Shapiro earlier today talking about how students are, the ones who often know when someone is at risk. So that's wonderful to hear. So I want to ask you both to pick, I know it's hard, but one intervention from your research, from all your expertise on this topic that you think is really promising, that is in the field right now to address youth mental health and suicide prevention.
Sure. So I think one thing that's important to take into account when thinking about these interventions for Latinx youth is just the incredible diversity of the Latinx community in terms of race, ethnicity, in terms of thinking about vulnerable subgroups that we often don't know that much about in terms of our national data. And so thinking about immigrant youth, LGBTQ+ Latinx youth, Afro-Latinx and Indigenous Latinx youth, which is something that can really be addressed most effectively on the local and community level because communities can really understand the demographics and the needs in these particular groups. And so an intervention that we work on and are really looking to develop further is around integrating community health workers both into community and primary care settings, really leveraging the strengths of people who are embedded in their communities, serve as community leaders or trusted providers who can then support clinicians and other health providers in delivering better care both to youth and their families who often need additional help navigating the mental health care system. And at the same time, there are a lot of challenges to be addressed to be ensured that we create a role for community health workers that is actually a beneficial role for them as well as employees within the healthcare system, that we don't replicate inequities of low-paid providers that are put at a different level in the hierarchy in healthcare. But I think there's a lot of promise to really harnessing the strengths in communities and among families to be able to engage in more effective suicide prevention.
Absolutely. And Holly, an intervention that you're excited about?
Well, it's clear to me, I've been in the field for a long time of suicide prevention, it's clear that we have to attack this problem from multiple angles and perspectives, and we need better coordination. The 2021 suicide mortality preliminary data is available, and we're now up to 55% of suicides were by firearm. So there's definitely, that would be one area where we could make a great deal of impact. But I think this idea of also coordinating better across funding streams and about people and with people in various disciplines to have a more coordinated and multi-pronged approach would be my ask.
Absolutely. Well, it's great to hear there's a lot of promising ways we can move forward. And we've been talking a lot about Latinx youth specifically, but as we started the conversation, suicide risk is rising for many youth of color. So I'd like to invite Dr. Allison Barlow, Director of the Center of Indigenous Health, to share with us her work tailoring interventions for youth suicide risk in Native American communities. Allison, can you tell us a little bit about what your work in youth suicide prevention looks like?
Yes, thank you, Inari. There's nothing more devastating than a loss of a child to suicide, to a family or community, and we have to feel that in our hearts to do better. Native American youth ages 10 to 24 have had the highest suicide rates in the United States for 4 decades. Suicide is a direct result of generations of racialized trauma that started with colonization. COVID has exacerbated suicide deaths. Native youth now suffer 3 times the rates of suicide than all other U.S. racial groups. Our work with the White Mountain Apache tribe shows there's hope and there's solutions. Over the past 3 years, it has led to the first of its kind tribally mandated suicide surveillance and case management system staffed by local Apache mental health specialists. We've been able to document over a 6-year period before COVID that the system reduced suicide deaths by 38% and attempts by 53%. In addition, through the Bloomberg Initiative, my colleague, Dr. Emily Harrows, sitting behind me, has led our work with the Apache colleagues to develop a highly accurate machine learning tool connected to emergency department data to help flag youth at highest risk. This tool embedded in the surveillance system helps us get to youth most at risk faster. With Native youth suicide on the rise, this work is urgent and there's much to learn from the frugal innovations that are being discovered by Indigenous peoples. Thank you to the initiative for focusing on ending suicide disproportionately affecting youth of color.
Thank you very much, Allison, and thank you, Kiara and Holly, for having this important conversation with us today.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.